All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Orthopedic Sports Medicine's virtual journal club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after the journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Orthopedic Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding the medical condition. Never disregard professional medical advice or delay in seeking it because of something you have seen or read or on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content which is provided as is and without warranties. For all athletic trainers intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevancesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and slides will become visible. The recording will be available for review tomorrow. So, Dr. Haidamous is a double fellowship trained orthopedic surgeon. He specializes in the treatment of various shoulder problems using the latest advancements in technology and cutting edge surgical techniques, such as minimally invasive or arthroscopic methods, as well as open procedures like anatomic and reverse shoulder replacements for individuals with shoulder arthritis. Dr. Haidamous received his special training in shoulder and elbow at the Florida Orthopaedic Institute and the University of South Florida in Tampa, Florida. And he completed a fellowship in orthopedic sports medicine at the Detroit Medical Center in Detroit, Michigan. He caters to a diverse patient population, including professional athletes as well as elderly individuals. Dr. Haidamous serves as a reviewer for the Journal of Shoulder and Elbow Surgery. His professional memberships include the American Shoulder and Elbow Surgeon Society, the American Orthopedic Society for Sports Medicine, and the Arthroscopic Association of North America. He holds an academic position as a clinical assistant professor within the orthopedic residency program at the University of South Florida Morsani College of Medicine, and he is speaking today about shoulder special tests for athletic trainers.
Thank you so much for the nice introduction. I appreciate this opportunity. Thank you. So I'm not sure if you can hear me well.
Yes, we can hear you.
Let's see if I can share my screen. Are you able to see my screen by any chance?
Yeah, and did you have the little button pop up that said, do you want to share your screen, or it says it's still waiting to view your screen? There might be a little button somewhere towards the middle.
Let's see.
If you don't see it, I can change it. Should have a little pop-up.
Oh, now I can see it.
Okay, good.
Are you able to see my screen?
I can see it.
You can?
Yes.
Okay, perfect. And the question, is it going forward? Does it show that? Because I'm on on a disclosure page.
Oh, and now it's on this disclosures. Yes. Right now it looks like we're waiting for it to go into presentation mode.
Let's see if I do this instead.
Now it's in presentation mode.
Okay, perfect. So thank you again for having me today. My name is George Haidamous. I'm with the Florida Orthopaedic Institute. I'm a shoulder and sports surgeon here in Lakeland, and we serve the Polk County. I'll be talking about the shoulder special test for athletic trainers, and I don't have any relevant disclosures for this talk. Shoulder injuries can definitely be a complex thing to understand and treat because the shoulder by itself is a complex joint. So I think it is key, plus it's an advantage for athletic trainers that they are able to see the mechanism of injury, like we see in the first image on the left. The player lands on their elbow, and this would likely represent a posterior shoulder dislocation, versus the second picture. We see a typical position, abduction, external rotation for a shoulder anterior dislocation. And the other thing, besides seeing the mechanism or understanding the mechanism of injury, physical exam is key in determining what's going on in this complex joint. And the last part of the process would be advanced imaging. So the outline of the talk today would be, we'll first talk about the anatomy, just to understand what the special tests mean in terms of the anatomy. And then we'll dive deeper into the labrum and biceps, then the rotator cuff, and then the AC joint. As you can see from this picture, the shoulder is a complex joint, many ligaments. This is, we're not talking about the muscles around it, but we will try to simplify the anatomy into biceps and labrum and the rotator cuff. So we'll start with the biceps and labrum and then talk about the cuff. So the labrum is actually, because the socket is a flat bone or a flat socket, and it has to contain a ball. So the labrum acts in conjunction with the capsule as a bumper. So the labrum acts as a bumper, kind of mimics the bumper that we see on the road to prevent the car from falling outside of the road. And the ligament is another key, very important structure that works with the labrum to prevent the shoulder from dislocating or to keep it stable. The biceps has a critical role as well. We are starting to understand it more and more, and it actually dynamizes the whole, especially the superior and the top part of the labrum, like a Chinese finger trap. It has a role in keeping the head centered and keeping it depressed. So what happens in athletes, we see some adaptations that happen, and these are adaptations that are, we don't call them pathologic. So they happen because of the amount of throwing or the demand on the shoulder. And we see here in the picture that even though external rotation in the second slide, or the second picture on the right of the athlete is higher, we see the total arc of motion is still the same. And we think that these happen over time. We see bony changes and adaptive changes to the bone, the ball, and the socket. So we have retroversion of these structures, and we have capsular changes. But sometimes, of course, pathologic things happen, and as we see here, the biceps, which attaches to the labrum, it's like a weed pulling type of injury, and we start having tears. And usually there's something that's going on with how the athletes are performing, and we know that the kinetic chain is a critical component that starts from the foot, the planting of the foot, and all the way to the core, so thighs, core, shoulders, elbows, to the hand, to the moment that the ball leaves the hand. We know that flexibility is key, and form is another important thing to prevent injuries. So all of these can cause injury if they are not properly prepared. So as clinicians, we try to differentiate good and versus bad injuries or bad changes. And usually good changes, even though we see tears, there's no disruption in the mechanics of the athletes and the individuals. Versus when we have clinically significant labral injuries, we start seeing changes in functionality. So the key here is the clinical exam, and to help us differentiate adaptive from pathologic, we need to evaluate the kinetic chain that we talked about. We need to evaluate the scapular motion and to see if there are any signs that tell us that this person has a shoulder at risk. So the kinetic chain, we look at if there's any hip weakness. We look at the quadriceps muscle bulk and see if there's any atrophy, especially in throwers, to see if the planting leg has any changes. And we look at the core and trunk flexibility and stability. So next would be looking at the shoulder, and we need to properly evaluate it by asking the patient to take off the shirt, because this will tell us or show us some signs that we can easily miss if we don't do that. One of them is scapular winging or scapular dyskinesia. And what happens when this happens, when we have this thing occurring, is the shoulder mechanics change, and we become prone to more injury. In this example, when we ask the patient to take off the shirt, we see muscle atrophy. That's the other thing we can find. And in older patients, we know that this can happen when we have rotator cuff issues, and in younger athletic patients when we have cysts that compress nerves, paralabral cysts, we call them. The other easy thing that we can find would be biceps tendon tears, as we see in this picture. And as we mentioned, the at-risk shoulders, we know that signs such as decrease or difference of side-to-side comparison of total range of motion more than 5 degrees, or external rotation more than 5, or internal rotation more than 20, for example, scapular dyskinesia can tell us that this shoulder might have an increased risk of injury. Another clues that we see on the field is trouble warming up, changes in velocity, loss of velocity control, and accuracy. So this translates into an increased risk of surgery. We can see that it can go up to 4 times, and that's where we see issues that we need to fix surgically. So clinical exam, this is the key component here that we're talking about. The labrum, We talk about the modified dynamic labor shear test. This is a test that has a sensitivity of 78%. So when we have a high sensitivity or a higher sensitivity, this is a good test to think about ruling out the disease. So if it's not present, it's unlikely to be the issue then. The way the test is performed is by abducting the arm and externally rotating at around 90 degrees, and we load the shoulder and we move it from 60 to around 120 degrees. And if we feel any clicking or painful clicking or just pain, that means that there's chance of having a slap injury, which is an injury to the superior labrum. The O'Brien test or active compression test, which also evaluates the labrum, we ask the patient to forward flex the arm to 90 degrees with the arm extended, internally rotated, thumb down, and resist downward pressure by the examiner. They do the same thing with the palm facing up. So if they have pain with their thumb facing down, that's when we say it's a positive test. Historically, we used to think that this has the best it's a typical test for the superior labrum, but now we understand that it has higher specificity and sensitivity, as we see here in the green area, to the posterior inferior labrum. That's where we see the highest sensitivity and specificity compared to the yellow part. Another test is the Whipple test. We ask the patient to place their arm close to the opposite shoulder and resist downward force. We then ask them to do the same thing with a pressure from the back of the shoulder by the examiner. And if they feel improvement, that's a positive test. The third test, another test, is the dynamic posterior instability test. It mimics a throwing motion of the athlete, which is again resisted by the examiner. And we try the test again, pushing back on the shoulder. If there's significantly more pain without the pushing back with the thumb by the examiner, that's a positive test. And the key from the slide is to show that sometimes a constellation of tests improves our diagnostic accuracy. And we see when we do the combo, we have 94 sensitivity and 95 specificity for posterior instability and possibly extension into the slap lesion area. So the idea is we have to have a good a group of exams that we can use to optimize our chances to discover or find out injuries. Posterior labrum tests also include the Kim, jerk, and posterior stress test. I grouped these together because they follow the same concept. What we do to load the posterior labrum is we try to get the arm to move from an abducted position to an adducted position, so moving inwards, which places the labrum, the humeral head facing the back, and with posterior pressure or loading, we see that we can have the head load the posterior labrum. So the Kim test involves, as you see in this picture, the examiner doing an additional outward or lateral force. The jerk test does not include that. The posterior stress test is just placing the arm in as you see it on the left side and pushing backwards without the movement, as you see in this picture. So this is a video showing how the test works, the posterior jerk test, which is my go-to test. So what's happening here is when the examiner goes inside with the arm, the shoulder comes out, and when he goes back into adduction or abduction, or the last move he did, as you see, so here the shoulder is dislocated, and then it relocates with a clunk. So a clunk or pain suggests injury or damage to the labrum and posterior instability. So another exam for instability, it can be used for anterior and posterior instability, is called the anterior posterior load and shift test. So the patient is placed supine. Typically, the arm is abducted to 40 to 60 degrees and slight forward flexion, and we actually load the humerus and we move it anteriorly or posteriorly. And the grading, as you can see, grade 1 is the humerus does not go past or moves to the edge of the glenoid. Grade 2, it goes past the edge but relocates spontaneously, and the grade 3 is when it stays out. And this is another video showing how we perform this test, and the best place to do it, or the easiest place for us to do it, is intraoperatively when the patient is sedated. We see how the arm is abducted, externally rotated, and the examiner is pushing the head out of the socket. A very common anterior instability test would be the apprehension relocation test. Again, same thing for the anterior shoulder. We're typically placing the arm in abduction external rotation 90-90, and if the patient feels apprehension and pain, that's a positive test for apprehension. If we push on the head, as the examiner is doing in the image on the right, and the patient feels relief, that's a positive relocation test. Sulcus sign is an exam for generalized instability when we have multidirectional instability. So we push down on the arm with the elbow flexed at 90 degrees, and if we see gapping between the acromion and the greater tuberosity, as we see in the image on the right, that means that's a positive test. The biceps, so many, I'm sure have heard of the speed and Jurgensen test. The nice thing about these is that they are highly specific, which means that if they are present, then most likely this is the problem, the biceps. So we're looking at around 86 and 97 specificity. The way the tests are performed is, for the speed, we ask the patient to forward flex the shoulder, arm, or the elbow fully extended, palm facing the ceiling, and we ask them to resist downward pressure. If they feel pain at the biceps area, which is the anterior shoulder, that's a positive test. The Jurgensen's test is, we see that the patient in the image, the one below, the examiner is trying to resist the patient's supination. So the patient is trying to supine or try to make the palm face up. And if the patient experiences, when doing this, pain at the anterior shoulder, that's a positive test. So the uppercut test is also a test that is used for the biceps tendon. It has a sensitivity and specificity of around 80%, which is, I would say, a good test to use to add to all the tests for the biceps. And again, we see that grouping tests together improve our sensitivity and specificity. One of them here, we see the examiner is, we call it the tenderness to palpation. So they are pushing on the or at the biceps tendon location. And if the patient has pain there, that's a positive test. So if we add this to the other tests that we talked about, we increase our sensitivity and specificity. Now the rotator cuff, so we're at the second section of the talk. We start about talking about impingement testing. So what we're trying to do is we're trying to get the greater tuberosity to impinge with the acromion or with the ligament, the coracoacromial ligament that's coming from the acromion. And as we see in the image on the picture on the right, we see the two arrows showing impingement of the bursa and the rotator cuff between the bones. So again, with the testing, we're trying to do the same thing. The near impingement sign, it's different from the near impingement test. So the near impingement sign is when we try to stabilize the scapula with one hand, and we lift the shoulder, we forward flex the shoulder, and when the patient experiences pain during the arc of motion, usually it's above 120 degrees, then that's a positive test. The near impingement test, on the other hand, is a different test. It's injecting anesthetic in the subacromial space and seeing if there's improvement in pain. Hawkins-Kennedy test is another important test for impingement syndrome. The examiner, what they do is they also try to impinge the greater tuberosity on the acromion or the ligament by forward flexing and internally rotating with an abduction movement. And that's another test. Now, strength testing. So we're now looking at the muscles, at the rotator cuff muscles. So the supraspinatus is the muscle that, or cuff that allows us to abduct the arm. And what we do, a very famous test is the Job's empty can test. We place the arm fully extended, thumb down, or internally rotated in the plane of the scapula, which is around 30 degrees anteriorly. And we ask the patient to resist upward or downward pressure. We see on the image on the right that the right arm or shoulder has good strength, but the left side has weakness. The subscapularis muscle is the muscle that allows us to internally rotate the arm. It's the one in the front of the shoulder or the scapula. Common tests are the lift-off and the belly press test. So we ask with the lift-off the patient to lift their hand off their back. So patients that have weakness or have tears are not able to do that. The belly press is we ask the patient to push on their belly and prevent the examiner from pulling their arm away. But I would say my favorite test in this category would be the bear hug test, because it has a higher sensitivity and specificity, or actually a higher specificity and sensitivity in detecting smaller tears for the subscap. So bear hug test, I would say for me is number one, and then I go to the belly press test and the lift-off test, which can detect larger tears. Now the external rotators, the infraspinatus and the teres minor, things that we can examine is one of them, the strength. We ask the patient to externally rotate and resist inward pressure by the examiner. So if we have weakness, then it's likely that we have a cuff tear. And the other thing is the lag sign. As we see in this picture here, the examiner brings the arm in external rotation and asks the patient to keep it in that position. If the arm falls back into internal rotation, that's a positive lag test. Hornblower's sign is when we have a tear or weakness in the teres minor muscle, and as we see here, we ask the patient to, as if they are blowing a horn, but in order, for example, in this case, the patient has a teres minor injury on the right side, because in order to be able to externally rotate his hand or arm to be able to get to his mouth, he needs to lift the whole shoulder compared to the left side. Finally, the AC joint. AC joint is typically something that we can, based on history, especially the type of fall, motocross injuries, biking injuries, or a direct impact on the shoulder, with the patient pointing to their AC joint, it's usually a localized pain or symptomatic place. We can tell that it's most likely the AC joint. And one of them is palpation of the AC joint. If we have positive tenderness to palpation, that's one exam. And the cross-body abduction test. So we, with the arm elbow fully extended, we go into adduction, and if this causes pain, that's likely the AC joint being the source of the pain. Thank you so much. Be happy to answer any questions.
I'm just pulling up the questions here. All right, our first question comes from Fernando. When there is a cyst that causes muscle atrophy due to nerve compression, what is the optimal time frame for surgical intervention? And when is it too late for surgical intervention?
So I would say when we have a nerve compression, typically we'd like to address this the soonest, because we know that muscle degeneration can occur, and overcoming muscle degeneration becomes challenging. So when we have this cystic lesion, we try to be as aggressive as we can to treat it, either by decompressing it, but we need to remove the compression from the nerve.
And then so that his second part of the question is there a time from your perspective that it would be too late for surgical intervention?
I would say we don't like to think of I wouldn't say that there's a specific time that we say that it's too late. It's hard to tell, because it's hard to tell when it exactly started. So we try to give the patient all the chances we can to decompress and see how it goes with physical therapy and optimizing the chances for them to heal.
Next question comes from Taylor, asking if you're concerned about a labral injury, would you start with an MRI or start with an MR arthrogram first?
So my go-to would be an MRI arthrogram, especially in young patients, and specifically when you're evaluating the labrum, because it improves your diagnostic ability to find these lesions. So MRI arthrogram, definitely.
The next question comes from Jessica. How often do you see a correlation between shoulder instability and the suprascapular nerve impingement? We'll start with that question. How often is there a correlation between instability and suprascapular nerve impingement?
I wouldn't say that I commonly see them together. I would say it's, so the suprascapular impingement, we think that it could be related to a slap type of injury, and these patients usually do not complain of specific instability. But what happens is the labrum, because of the tear, it allows for synovial fluid from the joint to kind of seep in between the tear and the bone and create the cyst, and this is how the cyst forms, causing impingement.
And so she asks, how can that be avoided or included in the evaluation? I'm not sure if that's physical exam testing. How can you assess for physical exam wise the suprascapular nerve impingement?
So the one, we talked about having the patient take off the shirt, right? So they take off the shirt. So the typical sign would be atrophy of the supra and infraspinatus. So we look at the back of the shoulder and we see when we compare the two sides that one side looks smaller than the other. And then they would complain of some weakness externally rotating or abducting the arm. So these are things that we kind of tell us there's something weird.
All right, the next question comes from Fernando. When a biceps tenodesis or tenotomy is completed, can that have a negative effect on dynamic stability of the shoulder?
So, ideally, I would say that we know, as I mentioned, we are starting to know that the biceps has an important role, and we know that because we're finding out that when we remove the biceps in patients who have massive rotator cuff tears, we remove an important part that allows for depression of the head. So it's a depressor, as we mentioned in one of the slides. So whenever we can, we try to preserve the biceps. But sometimes in the athletes, after you try conservative management, because I would tell you that we try to optimize as much as we can conservative management in athletes and avoid surgery. But if it happens that they failed everything, then biceps tenodesis is a good option. I wouldn't say it's the best, but that's what we have currently, versus because we know that sometimes repairing the labrum can cause stiffness, especially the slap area.
Brooke is asking, if someone has a rotator cuff tear, what are some of the indications that they would do surgery versus conservative management?
So a rotator cuff tear, I would say there are different components. So I would divide the rotator cuff tears into traumatic versus chronic. Chronic rotator cuff tears, we are starting also to know, and there was a very important study that came out by the Moon Group. They found out that 70% of patients with chronic rotator cuff tears who were treated with physical therapy did very well at did well at 10 years. So it's a good, I would say, that's how I tell my patients, you know, if you have a chronic degenerative tear, you can try, you have a 70% chance that you might do well with just, you know, conservative physical therapy injections. But traumatic tears, so patients that come in after a trauma, they have a regular normal shoulder use, and then out of a sudden after the trauma they lose function. These are patients that we know that we want to be more aggressive with. And the other important factor, I think, for me is that plays a role is age. So the younger you are, that's where you want to, maybe if it's not traumatic, maybe you try a short duration of conservative management, injection therapy, 6 weeks. If it's not working, you might want to consider surgery, because we know that tears can propagate.
The next question comes from Alan. Would you expect to see range of motion differences in throwing athletes, especially in external rotation, even without pathology?
Yes. So if again, the slide that I showed, it shows one of the athletes with the arc of motion, they have less external rotation, but they have more internal rotation. And the other person, because they are a thrower, a pitcher, they have more external rotation and less internal rotation, but the total arc is the same between the two persons. And the shoulder at risk is, as we mentioned, when we have a very big discrepancy, or like, as we mentioned, 5 degrees or 10 degrees or 20, based on which type of rotation we're looking at.
The next question is from Audrey. Is there a rehab protocol that you prefer after having a biceps tenodesis and the athlete has issues with extension and 90-90 ranges of motion?
So the question is,
yeah, the question, it looks like it's primarily, is there a rehab protocol that you prefer after having biceps tenodesis? And then maybe like, what are your secondary things that you might do if someone is having setbacks or not able to, they're kind of deviating from your typical protocol?
So I would say biceps tenodesis is actually, I would say we don't see very many issues with it. So the rehab protocol, I would say, is standard for, we use a standard rehab protocol. Definitely we limit you know, weight bearing in the beginning, just to make sure that the tendon heals, and we focus on passive range of motion than assisted than active. But it's definitely much shorter than a rotator cuff repair. So we allow motion earlier, because with rotator cuff tears, we immobilize for 6 weeks. We try to avoid the motion, but with biceps, we allow, once we have healing of the incisions, we allow some passive motion, and then we progress. So I would say standard rehab protocol. They do well. Patients do very well with biceps tenodesis. And you mentioned if they have a setback.
Yeah, so is there a rehab protocol you prefer? And the athlete has issues with extension and 90-90 range of motion.
I would say after a tenodesis, I would say if there's any limitation on motion, I would just continue focusing on rehabbing, getting the motion back, working on stretches, sleeper stretches, external rotation, just to try to get it back. Sometimes we do injections if we think there's certain capsulitis. So I would, the thing is, we need to understand why they have this limitation in extension. Is it capsulitis? That's a different treatment, because when we tenodese the biceps, it's typically non-restrictive. I would say there's something else contributing that we need to figure out. That would be with examination.
The next question comes from Matt. Can you speak about the role of the teres major and why it seems to cause so many issues in baseball pitchers?
Teres major. So the teres major, we typically, in at least in the shoulder practice, we don't see any major or common tears in it. So I would say that, to be honest, I haven't seen. Maybe we see sprains or something like that, but I've never seen like an actual tear in it. But sometimes tears can happen, and we need to fix it. Very uncommon. So the role, it's usually an internal rotator of the shoulder. But to be honest, it's not very common to see injuries in the teres major, maybe case by case. And again, we try physical therapy conservative. Sometimes, we can discuss if the patients like biologics, and then if things fail, we can talk about fixing the tendon.
Fantastic. That was a lot of good questions coming from our attendees. Yes, for sure.
That's great.
But yeah, so thank you so much for speaking today, for taking time out of your clinic schedule. We really appreciate it. I know our attendees really appreciate it. It looked like we had right around, there's over 90 attendees. So we had a lot of people coming from, a lot of local places, but also I know Matt's up in North Carolina. So just so lots of familiar folks and that are local, and lots of folks that are across the country that were attending with us today.
That's a great initiative. I was so happy to be here.
Well, thank you very much, Dr. Haidamous, and thank you to everyone for joining us today.
Bye.
Have a good one.